Lucky to have Lauren here with us this morning to give us a wonderful talk about some Naivasha case files. Lauren, take it away.
Thank you so much. Good morning, everyone. I'm Lauren Onofrey. I'm your Global Health Chief. Some of you I know, some of you I've never met, but it's great to meet you on Zoom. And this morning I'll be presenting several cases from Naivasha, Kenya, which is where we have our global health rotation, where we've had a presence and a partnership with this hospital for 10 years that I'll go into a little bit later in the presentation when I talk more in depth about global health at UW. But these are some cases from there, some that I've seen, some that were developed by previous chiefs, but that are very common presentations that I've seen several similar cases of, with the details coming from people like Colette Abbott and Mike Brody. And so without further ado, here we go. I have no disclosures. And the goals of this presentation are to practice clinical reasoning when you have limited resources, which happens very frequently in Naivasha, Kenya, but happens here as well. We're currently in a pandemic, as you all know very well, and sometimes things aren't happening as quickly as we would like, particularly imaging, particularly MRI. Staffing resources are a lot lower. So I think these ways of thinking and these strategies are relevant to all contexts. Although come up very, very frequently for residents on the Naivasha rotation. We will also review some common conditions that are epidemiologically more frequent in sub-Saharan Africa. And I would also hopefully like to encourage an interest in global health and sign you up for the Naivasha elective, which historically has been incredibly sought after, something that you sort of had to wish for to get it in the scheduling. But this year we have a few open slots. So if you would like to see similar cases like this and practice in this setting for a month, you are able to switch an elective, and I'll go more into detail with that a little later as well. So the theme for this first case is you can't always get what you want, but you often get what you need. So our first patient is a 35-year-old woman, and she's coming in with 3 weeks of dyspnea and cough. She was in her usual state of health until 3 weeks ago. Then she had pretty sudden onset dyspnea, and it's a non-productive cough. That's been worsening over the last 3 weeks. She denied any fevers, chills, weight loss, no orthopnea, no paroxysmal nocturnal dyspnea, no edema that she could detect. Also on our exam, we had no edema. Her vitals were notable for mild to moderate tachycardia. Her respiratory rate was 30, and her oxygen saturation was 89% on 6 liters with a good waveform. On exam, she was in moderate respiratory distress, but her lungs were clear to auscultation, and there was nothing else remarkable. Labs were drawn, but often take 24 hours to result. So we don't have labs back yet, and we also didn't have any KG because there's one machine shared between 2 buildings, and it's sometimes a bit finicky. So while the providers were aiming to get that, it had not been taken yet. We did, however, have a chest radiograph. So here it is. There's no radiologist, so your read is the read. And if we could launch a poll, please, share your thoughts on whether this looks like a normal chest radiograph, whether it looks like pulmonary edema, pulmonary hypertension, or hyperinflation. Or I suppose E, none of the above.
I'm gonna give just a couple more seconds.
All right, pretty good split. So many selected normal, and that's definitely what I very confidently told my learners on rounds the first time I saw this chest radiograph. Fewer people thought there was pulmonary edema, I agree. I don't think there's a lot of signs of edema, but several votes for pulmonary hypertension, which we'll go into a little more detail about, because after we reviewed this film with Dr. Ralph in Morning Report at UW, I learned that there were several signs of pulmonary hypertension. I often don't look that closely for pulmonary hypertension on a chest radiograph because we're gonna get the echo or they already have the diagnosis. But for this patient, we didn't have a formal echo and she did not come in diagnosed with high pulmonary pressures. But let's take a look at her chest radiograph right next to a normal film. So this is normal. This is our patient. And if we look closely, you can see signs of pulmonary hypertension here. So these are dilated pulmonary arteries. There are normal values for these, that if you're in a system where you can measure the diameter, you can compare to normal values. We didn't have that ability on round, but if you compare to this normal film, you can see that they're generous, that they're more radio-opaque and wider. So these are dilated pulmonary arteries. If you squint, and I never would have seen this without Dr. Ralph, this is a dilated azygous vein, which isn't really visible on a normal film, but in elevated pulmonary pressures, you can see the azygous vein become a little more prominent. She also has cardiomegaly. If you were to get out a ruler and measure, this is more than half the diameter. And this, in particular, in this pretty good, not very rotated film, it's driven by an enlarged right atrium on the right heart border. And if you squint, there can also be some elevation of the apex in elevated pulmonary pressures driven by dilation or hypertrophy of the right ventricle. And I think I can kind of see that as well. So if we were kind of drawing through the axis of the heart, like this would be normal. She's a little bit more tilted, and that elevation of the apex can be a sign of pulmonary hypertension too. So if you could get only one diagnostic test next for her, noting that we've seen signs of elevated pulmonary pressures on her chest radiograph, what would you get if any of these things were available? Okay, pretty wide split. We kind of want all of these things, right? An echo will delineate the kind of pressures within her heart a lot better and what exactly is going on with both the left side and the right side. A CTA would be very helpful. I think this is a pretty good story for pulmonary embolism. High resolution CT will give you a better sense of her lung field. Since we didn't see anything in the lung parenchyma on her chest radiograph, but a CT would be much better. And a right heart cath, I think at this stage, it wouldn't be my very next step, but would tell you about those elevated pressures. If I could have chosen one test, I would have wanted a CTA, because I thought with this kind of sudden onset in this previously healthy woman who didn't seem to have a prodrome of things kind of getting worse, like a story for a more chronic development of pulmonary hypertension, I would have wanted the CTA first. But I think the echo is a very reasonable answer as well. And in fact, we do have a portable ultrasound in Naivasha. So we were able to get not an echo, but a bedside cardiac ultrasound. So here we have a parasternal long axis view. This is the view that you get if you place the probe to the left of the sternum and kind of take a slice through the heart. So this is normal, and this is our patient. This is either the right ventricular outflow tract, or I caught more of a slice of the right ventricle. And then this is the left ventricle, the left atrium, and the left ventricular outflow tract, or aorta. And then the analogous things in her image as well. Right side of the heart, aorta, left atrium, left ventricle. And in comparing these two images, sorry that this one's a little blurry with the portable probe, what do you see? What looks abnormal?
The right ventricle looks huge.
The right ventricle is huge. So without going extensively into measurements, on the parasternal long axis, the right ventricle, the aorta,
Lauren, you may have frozen on some screens. I don't know if others have seen.
I thought it was me, but I think it's Lauren.
Okay. This is the danger of technology across multiple continents. So we'll see if Lauren can reconnect in a second.
She's in Seattle, actually.
Oh, okay.
Hopefully she pops back on.
Yeah.
So here is the apical four-chamber view, and same idea, the right side is huge. So a little more diagnostic data with some portable ultrasound, but still no CT, which was the test that many of you and I really wanted in that moment. So with the information we have now, which is signs of elevated pulmonary pressures on chest radiograph and right heart dilation on bedside cardiac ultrasound in this woman who had pretty sudden onset shortness of breath 3 weeks ago, without a lot of infectious symptoms, without a lot of symptoms of heart failure, what would you do at this point if you couldn't get additional diagnostics for at least several days? So I'm seeing a lot of votes for anticoagulation. Do we have enough evidence that she has a PE? I think our index of suspicion is quite high. I would say that's my working diagnosis at this point, and we did decide to anticoagulate her. I also see a lot of votes for diuresis, which dry lungs are happy lungs. She has a lot of dilation of the right side of the heart. The right heart will probably work a lot better if we diurese. Actually, I think that's a good answer as well. But we don't have a good story for infection. And that's something we're commonly talking about on rounds with brand new interns, that not everything pulmonary is pneumonia. We do want further diagnostics, but those aren't available and won't be for days. So it was unrealistic to wait for them. But I would argue that we have elevated pulmonary pressures and we have sort of localized the problem. The left side of the heart looked pretty normal on cardiac ultrasound. We don't think this is left-sided failure. We don't think this is like a mitral valve problem because there was no pulmonary edema, and we would expect if it were close, if the problem were closer to the pulmonary veins, then we would probably see more in the lungs than we saw in the lung fields on her chest radiograph. The lungs are pretty normal, although we don't have a CT. We didn't see anything in the parenchyma. But where we have localized the problem is that the pulmonary arteries are dilated. An RV infarct wouldn't do that. And the right side of the heart was dilated. So we've localized the problem somewhere here. So with pretty basic diagnostics and clinical reasoning, I think we got pretty far. And we had made the same decision on rounds to anticoagulate her based on the information we had. And several days later, when she was able to get a CT scan, she did have a pulmonary embolism. Something else I learned from this case after reviewing the film with Dr. Ralph was that the chest radiograph can be strongly suggestive of increased pulmonary pressures. I'll admit that I, in the past, haven't looked super closely, but when it's all you've got, it's a really valuable tool. And the ultrasound has been an invaluable resource for us on the wards in Naivasha. So I'll pause there and see if there are questions, points of discussion, clarifications on the first case.
There are no questions coming up in the chat.
All right, this was the first time that I had treated a PE without definitive diagnosis in this kind of setting. So next case, framed with a comic from James C. I think occasionally in high resource settings, I've felt like a really solid middleman general internist where someone needs help, they come ask me, I know who to call, and then this is me hanging out while they fix the problem, and then I learn from them. In Naivasha, you're the internist, and that's kind of a specialist level of training in that hospital. So there are instances where I've diagnosed things de novo that I've never had the opportunity before. So this next case is a 32-year-old woman who's coming in with headache, palpitations, and fatigue. She's had these complaints for about a week. Review of systems wasn't very remarkable. She was mildly tachycardic on exam, quite pale, but otherwise fairly normal on physical exam. Her CBC was notable for a blank space after the white blood cell count, meaning that the machine couldn't detect any white blood cells. Her hemoglobin was 5.3 and her platelets were 75. So for this 32-year-old woman with headache, palpitations, and fatigue found to have pancytopenia, I think your next diagnostic step would be a blood smear. We probably don't need to launch a poll because we need to take a look at what's going on with these cells. Why can't the machine detect any white blood cells? Is it because there are none, or is it because they look funny? We'd also want basic labs and coags, but I think that the next step we really, really want is a blood smear. And here's her blood smear. So to get a pathologist to look at a blood smear would have taken perhaps a week. It would have been a send out test. The family would have had to raise the funds beforehand, but the lab at Naivasha is able to make a film. They're more commonly used to doing that for malaria, but are happy to make a smear of just blood cells not for malaria, so you can look at the morphology. And these are her cells. There's no hematologist or pathologist. What do you see here? Throw it in the chat. Yeah, so people are pointing out rouleau formation. So here suggesting that maybe there's some kind of increased protein in the blood. And then the lymphocytes question mark, I think is referring to these cells, which are unusual looking. I see a comment about some neutrophils, which are probably these cells. But that lymphocytes question mark is what I want to drill down on. Blasts. Yeah, so these are blasts. And I think looking at comparing to a normal film, it might become a little clearer. So this is evaluating for acute leukemia alone in the middle of the night, either in a place without hematopathology, or if they're not in, or you're at a hospital in a more rural area that's not the UW. So part of this is that there are too many leukocytes. So this is a normal film with a lot of red blood cells and a handful of white blood cells. She has many. So when I first saw this, the read from the automated machine, I thought she had pancytopenia, but actually she has all these unusual cells. in addition, they don't look normal. So these are the various types of normal leukocytes. Here, neutrophil, eosinophil, basophil, macrophage, and lymphocyte. And these cells don't really fit in any of those categories. They have almost no cytoplasm compared to the giant kind of diffuse, indistinct nucleus compared to these cells where the nucleus is a lot more distinct. Another thing that I think you could consider is whether these are reticulocytes, but they're too big. Reticulocytes, while they have a nucleus and won't look like these little red blood cells, they'll be closer to the same size. So these are blasts, and the first time I saw them under the microscope wasn't really sure, but fortunately I graduated with a lot of brilliant clinicians, some of whom are in Hemorrhagic fellowship, and they confirmed our concern, both clinically, it's a good story for a new acute leukemia, and then seeing this smear where it doesn't look quite normal. I think the only time I had ever been the first person to see this was probably on step exams. But you can find yourself in situations where you are the one looking at the smear, and it's always nice to be able to phone a friend in those circumstances as well. So kind of the resolution of the case, which I don't have the full resolution of, she received blood transfusions for supportive care. The wards are open and have about 40 patients on them, 40 to 60 or so. So we placed her in a more isolated section of the ward just for infection prevention. And she was accepted at a quaternary referral center based on our read and the read by text of my friend from residency. So she was able to get to a higher level of care without the delay that the outside read would have taken.
Lauren, can I ask you to expand on something that you said about the family needing to raise funds? I think that this is maybe not familiar to a lot of people in the audience of what you're talking about.
Yeah, so I don't have a detailed understanding of the healthcare system in Kenya, but from what I've discerned being there for 2 months and talking with patients and providers, it's mostly a fee-for-service model, similar to ours in many ways. And if there's a service available at the public hospital, that can often happen upfront without having to pay for it in advance, like a chest X-ray, like a basic labs. And you can get results of that without the family having to pay for them before they happen. For more advanced studies, like getting a pathologist to look at a blood smear, like a CT scan, which is not on the campus of the hospital, the patient also has to be stable enough to transfer to get the CT scan. Those are things for which the family has to raise funds in advance and pay for that service in advance, which is a huge challenge to the care and can often limit our diagnostic abilities. Even if the diagnostic test is theoretically available, it may not be financially available, and that's a huge challenge of the healthcare system. So next case, or any other questions or clarifications on this case? Okay, so our next patient is a 62-year-old woman coming in with dry cough for 2 weeks. Cough is intermittent, but has been progressive over time. She also complains of generalized weakness and decreased appetite. Her family did report that she was HIV positive, diagnosed many years ago, but was not on medication. Cough, kind of shoddy cervical lymphadenopathy, and her labs were notable for white blood cell count elevated at 12.5 with low lymphocytes, hemoglobin 6.3, moderate hyponatremic, creatinine 2.3, and she had a cholestatic liver injury as well. Her chest radiograph, which I don't have in this presentation, showed that she was pretty cachectic, but the lung fields were normal, and I didn't see signs of pulmonary hypertension on this one. So what is the most likely diagnosis here? This is for a late middle-aged woman with untreated HIV who's coming in with cough, fever, tachycardia, AKI, and several abnormalities. Okay, pretty widespread. Probably because we don't see this so often, although I have admitted a few patients at Harborview like this. I would argue that the most likely diagnosis here is pulmonary TB, despite the normal lung fields on chest radiograph. I think PJP is also a distinct diagnostic possibility for someone who has a low CD4 count, and I would put that very high in my differential as well. Anyone can have community-acquired pneumonia. We usually like to have radiographic findings that are consistent with that, but in someone who's so immunosuppressed, you might not see it very well in a chest radiograph without more advanced imaging. And I do think there's concern for she could have pulmonary involvement of TB, but also involvement of other organs as well, given her state of immunosuppression. But I do think we have enough evidence here to have a strong suspicion for extrapulmonary TB. So thinking a little about tuberculosis, incredibly common diagnosis worldwide with active TB and total TB cases concentrated in sub-Saharan Africa, in Mongolia, Southeast Asia, and parts of South America and India. Globally, 1.7 billion people, so over 20% of the world population, are infected with TB. This number has been decreasing since 2003. Many of these, however, are latent disease that are not active tuberculosis. Annually, 9.9 million people will become ill with active TB, and 1.5 million people die from TB in any given year. Unfortunately, this was increased in 2020 in association with service disruptions with COVID, and that's the last year from which data are available, like 2019, 2020 from the WHO. HIV and TB co-infection is quite common, such that if a patient has one, you need to have a really high index of suspicion for the other. There are multifactorial reasons for this, but they both kind of feed forward into a perfect storm. So HIV, of course, causes immunosuppression and increases every concern about TB, both acquisition, progression to active TB disease, and increased mortality from TB in patients who have both HIV and TB. Tuberculosis also feeds into HIV disease being worse. So there's this theory, and this is a little more in the hypothesis stage, that there's immune activation from TB and that causes increased HIV progression and increased mortality from HIV as well. And it's important to note, in a patient with HIV and pulmonary TB, the chest radiograph can be completely normal, especially if the CD4 count is low. And that was new to me. I was used to having high concern for pulmonary TB really based on the chest radiograph. But if they're so immunosuppressed, they might not have infiltrates, even though TB is in the lungs. And extrapulmonary TB is also more common in patients with HIV. So for people who selected that would also be a very high concern. And as you also identified, other concerns with low CD4 count are PJP pneumonia as well, which would be something that we'd want to test for if we could get sputum. So this is an incredibly detailed question that I certainly didn't know the answer to, but this patient is diagnosed with TB based on Gene Expert. How would you initiate treatment? But for this as well. So I think a few principles here. For those who are prioritizing right treatment of tuberculosis and antiretroviral treatment of HIV, I think what you're recognizing is that both of these conditions need to be treated and need to be treated quite urgently. According to the data that we have so far from trials, for patients with a CD4 under 50, we delay antiretrovirals by 2 weeks. So in treating opportunistic infections and starting to get patients on therapy for HIV, we're balancing a few things. So there is a risk that when you allow the immune system to recover too early, like before there's been adequate treatment of the opportunistic infection, patients are at risk for IRIS, or immune reconstitution inflammatory syndrome, which can have a lot of morbidity and even mortality associated with it. However, there's also risk to getting on ARVs too late because you risk worsened outcomes from infection and other opportunistic infections in patients who have such a suppressed immune system. So there are various trials that give us these guidelines. So in patients with a very low CD4, it is important to get them on ARVs sooner than in someone with a higher CD4, because the adverse consequences of having such a low CD4 start to trump the risk of IRIS. These patients are very high risk for IRIS, but that's kind of how the balance of risk and benefits works out. For patients with central nervous system disease, which this patient didn't have any signs of neck stiffness or chronic headaches or other signs that would be suggestive of meningitis and meningoencephalitis, those patients we actually wait a little longer because IRIS in the CNS can be so severe and can have increased mortality. For cryptococcal meningitis, it's actually, there are different guidelines for high and low resource settings. In resource limited settings, we wait a little longer because the ability to deal with IRIS can be more limited. And those were data from a trial in South Africa published in New England Journal in 2014. So that was a learning point for me as well over the last couple of months. Okay. Next case. I think we have time. So next case is a 68-year-old woman presenting with weakness and confusion after being found down at home 8 hours ago. Past medical history notable for hypertension, and on presentation, she has markedly elevated blood pressure, 208 over 116, and on neuro exam, GCS is 8. Her pupils are myotic bilaterally, they're non-reactive. She has an upward gaze deviation, left-sided hemiparesis, although does retractive pain on the right side, and marked neck stiffness. Can't get a CT scan yet, both due to patient stability and the family not having yet raised funds. And so how would you manage her with this presentation, very concerning for stroke, but no CT scan? And I think this is really a data-free zone. I think it's an interesting point for discussion. I don't think there's a right answer here. And I have tried to find guidelines. There are a few opinion pieces I've read, but I don't think there's an answer. And I'm interested to see what people think. Yeah, so, and if people want to give their reasoning, I'd be happy to have more voices, but I think I can maybe infer as well what some of the thinking is. So for those who selected A, ischemic strokes are way more common than hemorrhagic strokes. So perhaps we should treat as though it's an ischemic stroke because it's so much more common. And there was a piece in the Journal of Neurology in 2014 that argued for this approach and did some data analysis saying that overall, taking this approach for everyone with stroke in settings where a CT scan can't be obtained will ultimately have net benefit. The next most common answer was D, which I think is a sort of like split the difference approach. It's withholding aspirin because we're worried that this could be a hemorrhagic stroke and we don't want to increase bleeding if it is a hemorrhagic stroke, but also trying to control blood pressure somewhat. So this is kind of splitting the difference between the aggressive blood pressure control that you might do for a hemorrhagic stroke and the permissive hypertension that you might do for an ischemic stroke. And then some answers as well for other kind of split the difference answers. And when I first encountered this, I was taking option B very frequently, where I didn't want to do harm by giving aspirin, but I also didn't want to do harm by lowering the blood pressure. But I think it's a really challenging situation and unfortunately very common. So stroke is the 5th leading cause of death in Kenya. It's the top non-infectious cause of mortality in adults in Kenya, and it's a huge cause of disability. So this is a very frequent clinical challenge that we're presented with. I think something that I've learned a little more recently that can start to inform the decision-making about this a little more is the kind of symptoms and signs that are associated with ischemic versus hemorrhagic stroke, which becomes a lot more prominent in a setting where the CT scan might be delayed. So we know that ischemic strokes are way more common than hemorrhagic strokes. There are some data in sub-Saharan Africa that there might be higher incidence of hemorrhagic strokes, so this might not be quite as skewed, more like 65-35. So the guessing on the majority side is not quite as clear cut. However, according to a JAMA Rational Clinical Exam article, there are some kind of signs and symptoms that are much more strongly associated with ischemic stroke versus hemorrhagic stroke. So for ischemic, if there's a preceding TIA, that's a pattern that's way more common with an ischemic stroke. Hemorrhagic strokes don't have that pattern as more. The patient is more likely to be alert. They're more likely to be in a coma if there's a hemorrhagic stroke. A carotid bruit might be the source of an ischemic stroke, so that's more associated with ischemic etiology. And neck stiffness from meningeal irritation from the blood of a hemorrhagic stroke is much more strongly associated with hemorrhagic stroke, as is severe hypertension. And there are likelihood ratios that have been calculated, and some of them are quite good. So the likelihood ratio is above 5 for someone in coma in terms of having a hemorrhagic stroke. And that cervical bruit makes an ischemic stroke way more likely. But they're not perfect. So a likelihood ratio of around 5 or a likelihood ratio of 0.1, it'll affect your post-test probability a lot, but not even remotely close to get what it would be if you could get a CT scan. So it's still clinical judgment, balancing risks and benefits, potentially clinical decision-making as well. Other thoughts or things to raise about the last couple of cases? I'll pause here for a moment. Ermias, I'm seeing you mentioning the Raj score to identify stroke types. I looked at that briefly, although I'm not as familiar with it. Do you want to speak on that a little more? I think that's very interesting and relevant.
Yeah, I am more familiar with the Raj score, but there are also different other types of scoring systems that are used in setups where there are no imaging to identify accurately. So, for example, the Raj score takes into account the level of consciousness, presence of headache, other signs of increased ICP, and the diastolic blood pressure. And then there are cutoffs to say this favors more ischemic, this favors more hemorrhagic, and then there is also like a gray zone. The sensitivity or predictive value is about 70%, not that great. There are also some other scoring systems. I'm not that much familiar with them, but I think it also depends on where the scoring system is developed and validated. Performs better in one side than the other.
Great,
According
thank
to
you.
Raj scores, these patients seem to have more hemorrhagic stroke.
Mhm. Thank you. That's something that I wasn't aware of and will certainly be using in the coming months.
Lauren, do you have any follow-up on any of these patients?
So this case was a case developed by Mike Brody. So this wasn't a patient that I saw, although I've seen other similar presentations, but I don't have follow-up on this one. For the first patient with the PE, that case was actually a bit complicated. She, the day after we made the decision to empirically anticoagulate, she developed unilateral hemiplegia and decreased level of consciousness. And I was very worried, given that we had just anticoagulated her, that she had had a hemorrhagic stroke, and we stopped anticoagulation. She was then able to get a CT scan, and it turned out that she had both PE on chest CTA and an ischemic stroke. So I think she probably had a PFO. We hadn't gotten the echo by the time she was discharged, but she improved a bit from both of those things and was able to be discharged home. The second patient with acute leukemia went to a referral center, and we don't get a ton of feedback back after that. So I hope that she did okay, but I don't have as much information about that. And then the patient with HIV and TB coinfection was also a case that Mike Brady developed. So I didn't see that specific patient, although I will say several of the patients who I've admitted with the team in Naivasha who have pretty advanced HIV and TB, unfortunately do die in the hospital. Some of them are able to get on treatment and do okay, but that anecdotally carries a very poor prognosis at our center and epidemiologically. So those are often sad cases. Other questions and comments? Okay, I want to spend a few minutes talking about global health at UW and in internal medicine at UW. I'll talk a bit about the Naivasha rotation, the pathway, and the TPR, which are all accepting applications. So Naivasha District Hospital is a 273-bed district hospital. It's about 100 kilometers from Nairobi, and it's a teaching site for Kenyan trainees. So it is a regional referral center, but not the highest quaternary center. we're the only international partnership and provide some of the a substantial amount of the clinical teaching when we have a resident presence there. The foundation of the Naivasha rotation is that it is first and foremost an education partnership. With that does come clinical care, but our goal is to be supportive and to help where asked rather than supplanting or replacing or providing the direct clinical care. We do aim to be a sustainable partnership. We've had a commitment in Naivasha for about 10 years, although that was limited during COVID. We aim for there to be bilateral exchange. So every year, except during COVID, unfortunately, residents and medical officers from Naivasha do come to UW to have an observership. And we've had positive feedback from both American trainees and Kenyan trainees that the partnership is valuable and that it has been helpful to learn the words from one another. And we do aim, so there's been a growing, very valid critique recently that global health activities of universities from wealthy nations are at risk for reproducing some of the exploitative patterns of colonialism. We aim to combat against that. We take direction from hospital leadership. We support the activities that are prioritized by the medical superintendent and the director of medical education. And they both have, of course, a very clear mind to the hospitals and the patient's best interests. So we make sure that we're aligned with that and are trying to have mutual benefit from this collaboration, both for the trainees and for the hospital and for patients. Our residents who participate in this rotation consistently report that it's a huge amount of growth for them during residency. You're making clinical decisions with limited data, and that really does hone your clinical decision-making skill. There's huge patient volume. You might be rounding on a full ward round day. You might be rounding on 40, 50 patients, and that'll really strengthen you as a provider. There's a ton of autonomy. You're teaching a team. You often during rounds are the most trained clinician. So you're developing how to be a leader in an environment where your learners know a lot more about the system and might have seen that condition a lot more than you. So it's a kind of a collaborative form of leadership with a lot of requisite cultural humility that goes into that. And it's a global health experience. You will be practicing and teaching in a district hospital in Kenya, which is more similar to the environment where many patients around the world are receiving care than is the ward at UW or the ward at Harvard Yale. It's also rated as a very fun month. So as far as wellness things for residents who do this rotation, there are no notes. It's daytime only and there are weekends off. So you do have time to travel and see the country. This is the gorge in Hell's Gate, which is quite beautiful. There's also rock climbing in Hell's Gate. And this is the Aberdares, which is just a few miles or a few hours away and has really, really gorgeous hiking and seeing support for no notes. I think that definitely contributes to clinician wellness. Notes get written, just generally not by you because you're in much more of a consultant, near attending role. And you should join us. So seniors, you can switch any elective this academic year to Naivasha as long as it's good with your schedule and with Kelly and with Whitney and that all of those things are in order. If you look on the schedule, you might see that there are already 2 internal medicine residents in a given month. We have plenty of clinical volume and plenty of space, and we can have 3, we can have 4. It's whenever it fits in your schedule, you don't have to do like tons and tons of shuffling. If you can just switch out one elective, I think this is a really valuable rotation. And our chiefs who are thinking about chief applications, think about applying for the Naivasha chief. I'm happy to talk about that one-on-one. It is common that people are applying before they've ever been there. So it's good to get more information. And then Carrie and I are happy to have conversations about that. Yes, thank you. So definitely you need to get permission for these schedule changes. We did have a meeting with Ken and Kelly yesterday confirming that these switches are possible, but they do have to follow all of the rules of the residency and make sure that you're still going to graduate and that the clinical needs at UW are being met. So there are details and a very strong asterisk to that promise. So thank you for noting that caveat. In addition, the Global Health Pathway is another opportunity at UW. So this is open for applications from interns, and it includes a month-long leadership course where you're forming a community, learning from leaders in global health at UW, and kind of learning different possible careers after residency and what those might look like. You also get several months of protected research and can participate in the Naivasha rotation. Most people do, but it's not absolutely required. And there are also community gatherings, and it's a nice group to have as you're going through residency. And so with that, thank you for your attention. I'm eager for feedback on this talk. It's a little different than talks we've given in the past. And I'm happy to talk more about the Naivasha rotation one-on-one. For questions about the pathway or applying for the TEAS here, Carrie would love to hear from you. And that's her email there. So I'd love to hear any other points of discussion or questions. And thank you for your attention.
Well, Lauren, thanks for doing this. To say it explicitly, in past years, we've had multiple senior residents who can talk about this experience to interns, particularly who haven't experienced it or don't know much about it. And so a lot of this is really to reintroduce it, because obviously with the pandemic, things have been very different. And so we're excited to get people back to Naivasha and back experiencing it. It's a wonderfully high rated experience for a lot of people, and for all the reasons that you said.